mainly focusing on the updates that recently came out regarding asthma management. And so those were really focused updates. So there we go. So of course, everybody knows that asthma is the chronic inflammatory condition of the airways. You've got airway obstruction that should be reversible, or at least partially. And there are usually hyper reactivity external stimuli. So those are those triggers that kind of cause the symptoms, and some degree of chronic airway inflammation. This is kind of more so what the airway is doing and what's actually happening when people are symptomatic or have been exposed to a stimuli or a trigger. So, of course, we know that asthma is an air trapping or an airflow obstruction. And the main things that I usually tell families is there's kind of three different things. There's the air wall swelling, which is that inflammatory process. There's also the smooth muscle contraction or the squeezing. And then you've got some mucus production. So there's mucus hypersecretions, there's hyperplasia of the goblet cells. And that is why usually you've got that dry cough. And then once we kind of treat the inflammation and that squeezing of the smooth muscle, that dry cough tends to turn into a wet cough. So those are just, of course, the symptoms most of us are aware of. I think one thing to point out too, of course, is our patient population, our younger ones, are not usually going to complain of shortness of breath or chest tightness. A lot of times they're complaining of my throat hurts, something stuck in my throat, my belly. There's lots of different things. So, but just to kind of point that out and remember when you're taking care of those patients. This is a really interesting slide that I wanted to just point out quickly. So over here on the left side of the screen, this is just a normal airway. And then about 10 minutes after this individual was exposed to an allergen or a trigger, you can see how significantly that airway is constricting. So you can imagine how severe reactions can be quite life-threatening. When we're trying to diagnose, so I'm going to say just a couple of things on this one and speed through because I really want to focus on our updates. But this is that predictive index that I was talking about. Oftentimes parents want to know how likely a child is that's younger to go on and really develop asthma. So this can just help counsel those families. One thing to point out there is that mom is more often to pass that and have that on in the history. And then seeing how significant even diagnosis of eczema is, that can lead to a higher index of developing that asthma. Of course, pulmonary function tests are something we definitely utilize. You can see here a lot of the T's in kids are often normal, or we have a really hard time getting them at first. We start to attempt at 4 years old, but it's a really difficult test to do. So as we work with them, hopefully we'll get a better quality. This just points out what kind of the difference that we're looking in. So obstruction, the FEV1 and the FVC ratio, and then we want some reversibility. Then you've got the body. But really, the next thing we usually do, or have been doing more recently, is a pheno, and then you can do the Bronco propagation testing. This is a little quick reference for just seeing what different type of FEV1 percentage and then the ratio as well indicates your mild, persistent, moderate, and severe. And so when we get these on the initial spirometry, we will then hopefully be able to do a pre and post and see if they do have that 12% at least 12% change reversibility, which indicates that that is consistent with airway obstruction and asthma. Things that we need to remember, of course, risk factors for more concern for sudden death, more severe outcomes. So history of sudden severe exacerbation, of course, ICU admission and intubation. If they've had frequent hospitalizations as well, or even 3 ED visits to the concerning their asthma within a year. Also, if they're using more than one canister of a bronchodilator, so the albuterol or the Zoflex within a month, and of course that does not include retreatment with albuterol. Then the other one that I wanted to really make sure to point out was sensitivity to the alternaria. That's a mold, so that's where that allergy testing really comes in, that we might get to talk to in just a second. Of course, we know how widespread the asthma is in our U.S. children. It is one of the #1 chronic conditions, to a lot of absenteeism, and also missed days of work for parents, financial stress. There's a lot of issues with a child that does have asthma, you can imagine. And so that's why it's so imperative for us to make sure we're doing the best we can to control them. This just kind of breaks down in different with child and adult percentage within the United States. You can see there's a slightly higher female prevalence, and then of course African American population definitely has not only a higher incidence, but they tend to have a more severe asthma. This just goes over some of our wonderful triggers that we have that can lead to some issues. I put the dog up there. That's usually a hot topic if there are, environmental allergens to pet dander, cats, dogs. And so just thinking about all those things and trying to really make sure we're figuring out what those triggers are and trying to help the families mitigate those as much as possible. One thing I want to point out too, emotions, not only stress, but also even laughing, getting excited. Some kids that are in choir, if they sing for a long time or loud, that can all trigger their asthma. So sometimes we actually have to pre-treat before band or chorus as well. So this just is a little great little image of really what's going on. You can see here that this is the normal, of course, but you can appreciate that there's more mucus and globule cells. So that's that nasty mucus production. So, and then you've got the tightening of the smooth muscle, so that constriction, and then you also have just the overall inflammation. So that nice trifecta that makes it really hard for our patients, for sure. So usually when I'm talking about that, I tell the parents there's usually 3 things that are going to happen. Squeezing of their airway, and that's when we use the bronchodilators, which help. There's going to be swelling or inflammation, and that's when we're needing that oral or that inhaled steroid. And then there's that mucus production. And so really the only thing we can do for that is opening up that airway and getting it out. And that's why we have that dry cough initially and usually that wet cough. And parents usually tend to think that's worsening, but it's actually meaning they're getting better. So here we are finally, kind of our asthma classifications. This is that guideline that we've been using since 2007. And particularly, we start off, of course, with trying to determine what the severity is. It's important to determine what that severity is based on pre-controller treatment, if possible. Sometimes that's not, those children have moved into the area or they come into our care already on one, but that is what's recommended. So you're really trying to get at what the actual intrinsic intensity of the disease is. And then you actually should choose whichever category, the worst, the most severe category that they have features of. And then after that and initiating therapy, we'll start reevaluating if they have poorly controlled, well-controlled and adjust their therapies as such. So this is the asthma severity. I just chose the age 5 to 11. The next slide can kind of put everything together. It's just not quite as detailed. You can see that we definitely focus on the symptoms. So you've got daytime symptoms, you have your nighttime awakenings, and then how often you're using your short-acting bronchodilator. And so the other thing that we want to look at is how much is it affecting the kids? And are they able to play? Are the parents feeling like they have to restrict their activity, which is a huge red flag for me? I want my patients to be able to be kids and participate as much as possible without limitation, if we can achieve that. And then once we're able to do the lung function test, you can see we're looking at the FEV1 and the FEV1 FET ratio. This is just a easier kind of all together across the ages what we're looking at. So if you can appreciate really what it shows you here is that we tolerate a couple more nighttime symptoms in the older population, and sometimes they may need more pre-treatment with albuterol, but really their daytime symptoms should be the same across the ages, if you can see that, okay? So you go from less than twice, the kind of the rule of twos. So if they're using their albuterol or their bronchodilator unplanned more than twice a week, or if they are waking up more than twice a month, you can see younger population, it's more than once a month. Or if they are needing, I think it says it on here, the next slide will. Then we go on to how many canisters you're using. Very poorly controlled, of course, is throughout the day, they're going to need it multiple times. And hopefully they're forthcoming with that so we know we can adjust it as needed. The other thing we always do is an asthma control test. If you guys have seen that, it's super helpful. It is definitely age focused. So we have different ones with faces for the little kids. And that helps us know also when to step up. I find it interesting that, especially in my younger population, the younger children, they actually read it worse than the parents do. So I don't know if that's because their symptoms aren't showing outward or they don't know to complain, or maybe that's just their baseline, kind of like kids that have bad vision. They put glasses on and they didn't realize that they couldn't see until then. This is kind of assessing the asthma control in children, okay? And so once again, it's just touching on when they come back, if they're well controlled, not well controlled, very poor controlled. It's just another little table to look at how to do that. This one, again, this is focusing just on the 5 to 11 age. Okay. So this is a lovely slide that kind of just depicts the stepping up approach as we have those kids coming back and being assessed. This, however, does not reflect the update. So I just wanted to point out, you have your intermittent asthma and you have your persistent. You definitely step up and down when needed. Of course, if you step down, you do want to at least have 3 months of good control. And then if you step up, you definitely, before you do that, want to make sure they're using their spacer, they're using their medication appropriately, as best as we can understand, and making sure that there weren't any major environmental changes. So these are the common medicines that we utilize, and we'll talk about those a little bit later, but I just wanted to list them there for you. This is that rule of twos that I was talking about. So of course we were talking about the older population. It's a little less for the 4 and under, but this does add in. So this is 2 canisters per month. Some literature says 1. I think that if you're using 1 per month, that's a lot. And again, that is not including our activity-induced pre-treatment ones. And then if you look at other literature, it'll also say if you've used 2 courses of oral steroids within 6 months to a year, then that's another thing that's telling you they're poorly controlled. So this is just pointing out that the clinicians, of course, this is kind of just hey, this is a guide. We definitely still know our patients, know there's certain special circumstances. And so we need to adjust the therapy to achieve asthma control. And you definitely want to have the parent and patient input on that. If we don't have good buy-in, then there won't be good compliance. This is a new one. Some of you might have seen it on some of our consults. So FeNO is something that we have been able to utilize a little bit more now with not being able to do our spirometry without COVID testing and isolation, which is difficult for our families at times. But right after, probably a couple months after we started that, this update came out, which was nice. And it does just state the fact that if you have individuals that are 5 years and older, and you're uncertain if they have a diagnosis of asthma, just using history, clinical findings, and spirometry, or if they're not able to do spirometry, then it is recommended conditionally that we can also use FeNO as an adjunct to that. It is never to be used alone to diagnose asthma. And I definitely want to point out that there are multiple things that the fractionated expiratory nitric oxide, which is what the FeNO is, it is definitely affected by allergy like sensitivity. So food allergies, if they have bad eczema, if they have allergic rhinitis, that can also have the levels go up, and it doesn't have anything to do possibly with their asthma. So you kind of have to interpret it with the whole patient. So this is the updated version. This is, you can actually get this printed off, and I'll send that link out if I think I included it at the end. But it's the Asthma Management Guideline, and it's an at-a-glance guide. So it's really nice. You could shrink it down and have it in your pocket if you really wanted to. So just really touching on the main things that we have that are new. So the new things are going to be indicated by this little triangle here. And so this is, of course, just for 0 to 4 month old or 4-year-olds. Another time. But so the big thing that I wanted to point out here is that at the start of respiratory tract infections, we can now, it's recommended that you can add a short course of ICS. So what that would kind of look like is if you know a child that has had recurrent wheezing, which is defined by more than 3 episodes of wheezing triggered by an infection, or 2 episodes in the past year. So the 3 episodes in their lifetime or 2 episodes in the last year with no symptoms in between, then this is an appropriate course of action. So when we prescribe this, the studies that they looked at, 2 of the studies, they were based on nebulized budesonide. So 1 milligram BID, so that's times 7 days. Okay, and that is just to prevent them from needing oral steroids. And then the other update here that's different that you can see is in step 3. So in step 3, they initially did not have the LABA. It was just an inhaled steroid. So they've now conditionally added doing the low dose LABA and PRN albuterol or Zofanax. And then if you see or, that's what it used to be. Okay. I think that's really it for the 0 to 4. And so the next, let's see. this is just kind of breaking down exactly what we were just talking about. Okay, so that is the 3 treatments. So this is the intensity. This is where really utilizing the asthma action plan, even if they still just have a diagnosis of wheezing, is helpful. That gives the parent and empowers them to know when they may need to have increased use of the SABA, and sometimes they need 3 treatments. So like NEB, 15, 20 minutes later, NEB, 15, 20 minutes later. So we'll do that back to back 3 times. But of course, we counsel them to give us a call and let us know how they're doing. Okay, so this is the 5 to 11. And so let's see. This is really the big thing, I think, in my opinion, that the update has really done. So they are now saying that you can use daily and PRN combination low dose ICS and formoterol. So what that means is if they have symptoms and need to use their quote unquote controller medication, in addition, then they can do that. It really comes about with there's this question of whether or not there's adherence and they're taking it appropriately. And so that was one of the reasons that they found this was helpful. And so to put that into perspective, so if you look, I think I have it on the next slide. Yeah. So it says 1 to 2 puffs as needed, but you can have a maximum total daily maintenance and rescue dose of 8 puffs. So that's, way more than we're used to, but it has been shown to be quite effective and safe. And then let me go pop back here. Same thing. I think that is it for that one. And then just pointing out, of course, they have this as they're highlighting it as new. I don't know that it's truly new. As more so, we're just we should be considering it more, I guess. Is that allergic component? So most oftentimes children's asthma is an allergic asthma, and so in an effort to mitigate their triggers and improve their asthma control, we should be thinking about whether or not they need to have immunotherapy. One thing I would say is if they are having PFT, spirometry, and they have, anywhere really mild is okay, but if they have moderate to severe obstruction, then they aren't really a candidate for an immunotherapy until we get them better controlled. And then in step 5 and 6, this is just alluding to the Xolair or a biologic. So those have been, we've been using those more, getting great responses in our patients. So that's an option too. And then again, this is just breaking it down into the 12-year-olds as well. I do believe with the 12-year-olds, yeah, they can get up to 12 puffs. So, we all have to adjust. We're evidence-based. Initially, when you think about it, I think, at least for me, it kind of made me a little nervous. But I have a couple of patients that are candidates for this. And I'm interested to see how things go when they come back for their recheck. So we'll see how it goes. And then just real quick, I think I'm almost out of time. So this is a great resource you guys can get. It just kind of breaks down all the different medications. People don't remember their medications, so for them to come up and point out, or if I'm suspecting that they're not quite telling me the truth, I'll ask them to point out which color inhaler they're using and when. So, and then this just kind of breaks down the inhaled steroids as well as their different dosing. So you guys can look at that a little further. This is, of course, your ICS with your lavas as well. And these are the references. I really wanted to go over addressing control and really evaluating how important it is to evaluate if patients are utilizing their medication administration appropriately, and making sure we're prescribing the correct